In this video, we'll be looking at how drugs interact, why they interact, and how to manage them. So you should be able to classify the drug interactions, explain the consequences of different types of drug interactions, and outline some strategies to manage drug interactions after this video. So there are two main ways of classifying drug interactions. The first being a pharmacodynamic interaction, where you might get additive adverse drug reactions. So, for example, two drugs causing drowsiness will make the patient more drowsy, or two drugs that dry out the mouth will have a worse impact on salivary flow. Or they could be antagonistic in their properties. So one might cause vasoconstriction and the other one causes vasodilation. The other second main category are pharmacokinetic interactions. So these are anything that will interfere with the absorption, distribution, metabolism, or excretion of another drug, and we'll unpack that in a bit. I'd also like to point out that most of the time we're talking about drug interactions, we talk about drug-drug interactions. For example, apixaban and ibuprofen, an anticoagulant and a non-steroidal anti-inflammatory drug. But we can also talk about drug-food interactions. For example, grapefruit juice, which is a cytochrome enzyme inhibitor, and interacting with a substrate for cytochromes, for example, amiodarone. Or a drug disease state interaction, for example, the use of beta blockers, which can mask hypoglycemic symptoms in a patient with diabetes. So let's have a look at a few different types of drug interactions which are pharmacodynamic in nature. So the first one on the list here is excessive hypertension that occurs when you mix nitrates and phosphodiesterase inhibitors. So nitrates will stimulate guanylate cyclase, which makes cyclic GMP, and then that cyclic GMP is going to be broken down by phosphodiesterase into GMP, or guanyl monophosphate. Now, if the nitrate is stimulating cyclic GMP and the phosphodiesterase inhibitor is inhibiting its metabolism, you'll end up with a buildup of cyclic GMP, and that leads to the excessive drop in blood pressure. Another type of interaction that I've already pointed out is the antagonist type. So levodopa, which produces dopamine, is an agonist and stimulates the receptor to change its conformation and do something. Metoclopramide is an antagonist, so it binds to the site and prevents the main agonist from binding to it. So a combination of these two will be counterintuitive because they will prevent each other doing what they're meant to do. A third example here is QT elongation. So this is the heart rate, PQRST, and what happens is that when that drug is present, it increases the time interval between the Q and the T wave. And the longer that becomes, the more dangerous it becomes for the patient, because what can happen is Torsades de Pointes, which is an arrhythmia. And you can see that it's quite different from the normal PQRST waveform that you would normally see in an ECG. So let's have a look at pharmacokinetic interactions now, and we'll start with metabolism interactions. So one example here is the cytochrome inhibitors, and when these inhibitors are present, they will reduce the Vmax of these enzymes, so the maximum velocity that those enzymes can remove the substrate. In this case, metronidazole is the inhibitor and amiodarone is the substrate. And what happens when the cytochrome enzyme comes along to chew on that metronidazole? It's like chewing gum. It gets stuck a little bit and it takes time to chew through it. Eventually it will, but the amiodarone will stay around for longer and it will take longer to be cleared. And so you will end up with more side effects as well as more effects from the amiodarone. The other example is a cytochrome inducer, and what this does is it increases the expression of the enzymes, so there are more of them. So for example, carbamazepine, it's an anti-epileptic drug. It makes more of the cytochrome enzyme and it will chew up more of the substrate, in this case estradiol, which means that that estradiol concentration, the steady state concentration of estradiol, will actually go down. Let's have a look at some pharmacokinetic interactions of the other parts of the ADME system. So starting with absorption, so antacids and doxycycline are examples where this occurs. So the doxycycline will bind to iron or magnesium, and when it does so, it's more positively charged, and so therefore its absorption is reduced. So separating these two is recommended, and it should be one of your counseling points. Another example of a pharmacokinetic interaction that affects distribution of a drug is an example where warfarin binds to albumin, and it will carry around. Now when it's bound to the albumin, it's not going to have much activity, but it will stay in the body for longer, and it's only when it becomes unbound that it becomes active. Now what can happen is that aspirin and warfarin bind to the same site, and aspirin can displace warfarin. So now the warfarin is not bound, which means it's more active. Yes, it can also be metabolized and excreted, but it's also more active, and so therefore you end up with a change in INR, which could lead to a bleed in a patient. The last one on the list here is pharmacokinetic interactions that affect the excretion, so the physical removal of the drug from the body. So the example here is penicillin using the organic anion transporters, and it moves it out into the lumen and where it gets passed in the urine. Now there is a drug called probenecid, which will actually block this activity, and the penicillin will stay in the blood. Now this is actually used in an advantageous way, because what it will do is it will increase the amount of penicillin in the body, so therefore it will do more killing of the bacteria, and so therefore it's actually beneficial. But probenecid can, because it interacts with the organic anion transporters, there are other drugs that try to use this transporter to get out of the body as well, so it can have negative consequences for other medication. So let's have a look at managing these drug interactions. So the first one is obvious: remove the offending drug. Now that's useful if it's not required, or if you can stop it for a short period of time while you're doing a short acute treatment, and then you can restart it afterwards. Secondly, you can replace the offending drug with a less offensive drug. So for example, you've got drug A and drug B. This one has lots of anticholinergic side effects, and B has very few adverse anticholinergic side effects. So you'd go for drug B because it has less side effect profile. Another one would be choosing a drug that is not a cytochrome inhibitor. So if it's just another substrate for cytochromes, then you have less likely chance of an interaction. Thirdly, you can do a dose adjustment, which works with cytochrome inhibitors and inducers. So if you're using a cytochrome inhibitor and the patient's also taking a cytochrome substrate, you may have to reduce the dose of the substrate because the inhibitor is going to increase it anyway. So that's one way of getting around it. And a lot of the time you'll see this as a dose titration, particularly if the person's already taking the inhibitor, then it makes it easier to titrate to effect. The fourth one there is space the time out between each drug as it's taken. Now this works well when there's a physical interaction, so particularly in the gastrointestinal tract, the antacids and tetracyclines is a classic example where that actually works. Where it doesn't work is if the patient is taking a cytochrome inducer, because this is a change in protein expression and that's not short term. The cytochrome inhibitors are also not particularly short-term. As long as the cytochrome inhibitor is in the body, which could be for 6 or 8 hours or maybe 12 hours, then this spacing of the drug administration is not an effective strategy. Okay, so we've looked at classifying different types of drug interactions. We have the classic pharmacodynamic, which is the activity of the drugs that might be sitting on top of each other and replicating each other, or we might be looking at pharmacokinetics, where we're looking at cytochrome inducers or inhibitors, or maybe something that affects the absorption of the drug. Secondly, we looked at the consequences of different types of drug interactions. So we looked at pharmacokinetic ones where you might see a lack of absorption, therefore a lack of effect, or if you're looking at cytochrome inhibitors, you might see a greater effect of those drugs and more side effect profile, or a worse side effect profile for that drug. And thirdly, we looked at strategies to managing these drug interactions, where we looked at either removing the offending, replacing it, or spacing it out differently, or changing the dose of one of them.